Thus, let me give you a critical thinking question. Patient comes into the EC complaining of left anterior rib pain. Which oblique would you perform?
Wait, repeat.
Patient comes in the EC complaining of left anterior rib pain. Which oblique would you do? RAO. Because left anterior rib pain. RAO is the P oblique will elongate the left anterior side because these obliques are looking at the side that is up. See how that can get really tricky? What I would do, even today, guys, is make yourself a chart with all your obliques and write out what side's being elongated. What are we focusing on? LPO, left posterior. RPO, right posterior. REO, left anterior. LEO, right anterior. I would write that in the form of a chart. That's something you can reference if you see these critical thinking questions.
Let's do it together.
Someone with good handwriting want to write it down? Come on, our resident artist
You got
here.
it, James? Yeah, you sent it last time, so just go.
For ribs though.
That was for chest.
It's the same thing.
Go ahead and write it down,
What am I
Jay.
doing?
Let's go. Let's write LPO, RPO,
Big.
and then LEO and REO. So, with a little bracket on the side of the pairs on the left side, for LPO and RPO, right, those are AP obliques. That's another way that you can say it.
So
On the left side of it, put AP obliques.
on Pia?
Uh-huh. And then put PA obliques on the other two. All right, so let's go ahead and label the stars of our shows on each of these positions. LPO is going to be focused on the left posterior ribs. It also is going to have the left side touching the IR. We want to write that as well.
Put an L. Yeah.
Y'all can talk about other stuff. It's like kind of awkward.
We're watching very intently on how you draw that box.
Angelica, may I use your marker?
What marker?
Cool.
Oh, that's bad.
Going too much.
Come on now, you gave me an
Miss Dempsey,
opportunity.
that's y'all's fault.
So RPO shows the right posterior ribs, and that's going to have the right posterior surface touching the IR.
I mean, I asked nicely.
So let's go to LEO. LEO is going to show the right anterior ribs. LEO shows the right anterior ribs. But the left side is the side that's down on that one. REO shows the left anterior ribs, even though the right side is now touching. For all of these, we are marking the side down. And once again, I'll show you on radiographs why that is.
So then on the right anterior, the left side is marked.
Correct, because the
Okay.
left side is touching. And this is going to be a very important chart to memorize and write down even to your registry because, like I said, one of their favorite critical thinking questions is to give you a scenario of someone complaining of a certain type of rib pain, and you have to explain or pick which oblique you would do to show it the best.
Now, if they complaining about anterior and posterior right side, you do
You do
anterior and
both.
posterior. Yeah.
Yes, you do.
You know, on the first note,
Yeah, I'm sorry, get carpet tone.
It's a really good chart there, guys. Yep.
Markers are my favorite.
LPO would be the same as, and then.
Yes, that's another good question too. LPO can be considered synonymous with REO. LAO can be considered synonymous with RPO if you're just glancing at them on a radiograph without markers, which is why I'm talking about marking stuff correctly. They look the same on a radiograph, even though they're looking at different aspects. We're gonna keep reviewing, don't panic.
But
Don't
can't you
panic.
tell because there's like the floating ribs, so you would be able to tell when you were.
They don't show up on the
Tell what?
interior.
If it was.
Not exactly, because you're gonna see them regardless, even though one might be more clear than the other. Sometimes the difference is so subtle, you still need to rely on the marker, just in case.
Yeah, no, but I was just saying, but I was just saying, like, 'cause, you know.
That same thing. But you just remember that the ribs
You're
are
still gonna see it on both. APO, regardless, just one might be slightly clearer than the other.
She's cool. She's fun to have.
Yes.
I'm
Okay,
excited
so
for her
for the PA
evaluation.
LAO, you're looking at the right interior rib.
Yes.
So the right rib go down?
No.
She's almost done.
So PA oblique. Alright, let me just position myself. Which one did you say, REO?
LAO.
You said LEO. LEO means I'm touching my left anterior surface on the IR at 45 degrees. But what am I elongating? The right side. I am focused on the right ribs. REO, my right anterior surface is touching the IR, but I'm elongating the left anterior ribs. So for these PO obliques, we are focused upon the side up. AP obliques are focused on the sides that are down. So they're inverse.
So which marker do you put down? The side
Y'all are really panicked about these markers.
If you're
I
doing
told you,
REO, you're gonna put REO
Wait,
down.
we're gonna get to the markers. I promise we're gonna get to the markers. Let's talk about positioning first, though. We're gonna talk about the markers. For now, I just want you to write, we're always marking the side down regardless of what we're looking at on ribs. We mark the side touching the IR regardless of what the star of the show is. Just trust me on this for now. Alright, let's just go through some of the positioning. We're gonna come back to the markers, I promise. So same thing, guys, on positioning. Once again, not incorrect either way, but one's recommended over the other. Upright ribs, it's preferred for you to stand. Lower ribs, it's preferred for you to lie on the table. Phone. Your own personal preference. That's what's considered optimal. We're still at a 45-degree oblique. We're just facing the IR as opposed to putting our back on it for REO and LEO. Once again, who's the star of our show for these obliques? The affected side away from the IR. Thus, REO focuses on the left side, LEO focuses on the right side. Y'all still with me there? These always throw people off. Now think about it as well, because arm positioning is also important. Remember when I said on the other two obliques, the side that you're focused on is the arm you want to raise, correct? So for an REO, because we're looking at the left side, we're going to raise the left arm, like we see in the picture here. For an LEO, because we're focused on the right side, we raise the right arm. Whatever arm you raise, the opposite one's going to be on the hip. Okay?
And that's the opposite of the AP oblique, which is the side that's touching is the arm that's up.
In a way, yes, but the way I would encourage you to think about it, which is easier, what side are you focused on? Whatever side you're elongating is the arm you want to bring up, even though they're inverse to each other.
So, which arm would you put up for?
For LPO, you're going to raise the left arm, we're looking at the left posterior side. RPO, we're bring the right arm up.
That's for the AP. Okay, so PA.
For PA, REO, because now we're looking at the left side on REO, left arm goes up. LEO, right arm goes up. So I said a chart's going to help you out on this test.
So we'll be lifting the arm on the unaffected.
You're lifting the arm of the affected side. The side that you're elongating is the affected side.
This one, the CR goes to elevated, so.
Yes, we're gonna get to the CR in a second. So this one does follow that same rule of obliques as opposed to the AP obliques where I said stay on the sternum. For PO obliques, we will go ahead and center on the elevated side of the patient, halfway between the lateral aspect and the spine. So what I always do, guys, is I'll always, let me show you with Mr. Bones here, when I'm doing the PA obliques, I'll put one hand on the spine, one hand on the side of the patient. This is our elevated side. bring my thumbs together, and that's where I put my crosshair. That's the easiest way to find that centering for that one. Hand on the spine, hand on the side, thumbs together.
You don't have to do that for either.
No, AP, just put on the sternum. That's the only exception to the rule. All right, guys, same exact thing we just talked about with all the other positions. IR for your upper ribs, 1.5 inches above the shoulders. For the lower, put the bottom edge at iliac crest. Upper is a lengthwise, lower is a crosswise cassette. That has not changed. We'll spend some extra review time on this on Friday too. This always gives people trouble. It's not uncommon. We'll even do some in-class demonstration if that helps.
On phone?
On each other. It's better if you just do it yourself. We'll all find a wall and we'll position these obliques. That'll help you out, trust me. All right, so we're still using a perpendicular central ray, 14 by 17. Same aspect on the breathing, guys. For the upper ribs, full inspiration. Lower ribs, full expiration. What are we looking at? The same area, those axillary ribs, but for these PA obliques, we're doing the axillary ribs farthest from the IR, or as we say, the axillary ribs of the elevated or the upside of the patient. And that shows you that centering once again, guys. For these, we're going to center towards that elevated side, directly in the middle, halfway between the spine and lateral side of the patient. Which is why I said put one hand on the spine, one hand on the side, bring your thumbs together. It's going to help you center for that one. Okay? It's gonna start making sense, just trust me. All right, so what's our evaluation criteria, guys? Still looking at the axillary portion of the ribs. We want them to be free of superimposition, away from that central spine. For the upper, 1 through 10. Lower, 8 through 12, that has not changed. And ribs should be visible through the lungs or the abdomen. Now, to show y'all what y'all are asking, look where this marker is. This is an REO position. This is an, I'm sorry, is it LP?
You can do it.
LAO position. LAO position. We always mark the side that's touching the IR. Now for the PA obliques, that's going to be the side that's foreshortened. Now why am I marking the side down on this one? If I had a right marker here, how do I know this is not an RPO? I wouldn't know. Which is why on ribs only, this is how the marking rule works. For REO and LEO, we're marking the side that's touching, even though we're elongating the opposite side. LPO and RPO, we're also marking the side touching, even though that's the one that's down. Why? Because if I don't do that, I wouldn't be able to tell the difference between, if I had an R here instead of an L, I wouldn't know if that was an RPO or LEO. I could make a mistake on that. Why is that important? I could be telling the doctor I'm looking at the wrong side. He's gonna look at that and be like, well, RPO, this means posterior rib pain. I don't see anything with the anterior, they're fine. They completely missed that. So that's why I said, once again, write a chart. I will make sure your lab teachers know this. It's very important that you mark it this way correctly, because otherwise you wouldn't be able to tell the difference between the two obliques. They look almost exactly the same. There are subtle differences, but if you're just glancing at it, it'd be easy to make a critical error of which side you're looking at. So, REO, right marker, because the right side's touching. LEO, left marker, because the left side's touching. LPO, left marker, left side touching. RPO, right marker, right side touching. The marker is not telling us what the star of the show is just telling us what side's touching the IR so we can determine what specific oblique we're looking at. So some of y'all nodding your head and some of y'all looking spaced out. Is that making sense?
It's always marked.
So markers have nothing to do with what the elongated side is, it's just what side's touching the IR. So we're going to identify the specific oblique. Yes?
So it's important to have some light on the other side, you know.
You're going to regardless. You're always going to have a little bit of that side showing. Yeah. And even if your marker's in the ribs, we don't care about this side. This is what we're looking at for this X-ray right here. So it's okay if it's in those ribs slightly. Yes.
So always mark down the side that is touching. no
Always
matter
mark down
what.
the side that's touching on your oblique ribs.
Just for ribs?
It's
though?
just for ribs.
Okay, I was about to say.
Just for ribs.
Questions.
Just for ribs, guys. And that's how you can determine the difference between your obliques. Otherwise, they're gonna look almost exactly the same.
I think I'm getting a call from IT, like Harris Health. Can I take it outside or?
It's up to you. It's totally up to you.
Okay.
I can't stop lecture though.
Okay.
RAO, we're looking at the left anterior. With the right marker.
Correct. You got it. All right, let's do some review questions, then we'll look at a few more images, guys, to review what we're looking at, okay? Any more questions on that so far? If you're still feeling like you're a little foggy headed on that, we're gonna hit it on Friday as well, and we'll even position in class to review all that. It'll help if you do it with some hands-on, okay? All right, what is the degree of obliquity for the PA oblique projection of SC joints? 10 to 15. Now notice I did put that old faithful 45 in there, but that didn't trip you up. But just keep in mind, that's a very slight oblique. We're not using 45. The only 45-degree oblique this chapter is those ribs. The other ones have more specific degrees of obliquity, that being the sternum and the SC joints. What's the degree of obliquity for the AP oblique projection of the ribs?
45.
Oh, it's not 15. That one's the old trusty 45. That's correct. That's correct. Just be careful. Easy points to throw away, guys. Pay attention to those obliques. Make sure you know what the question's saying, what you're looking at. A lot of times we see that word right there, guys. Oh, oblique 45. It's a dangerous move to make, especially this semester, because we're going to have a lot of different types of obliques that we're going to start hitting. I heard one of y'all groan, but yes, it's true. Which of the following would best demonstrate the posterior ribs above the diaphragm? Ooh, that's a good critical thinking question there. Be careful. Posterior ribs, look at your key words.
B.
Posterior ribs above the diaphragm.
B.
C is in dog. I
B
mean
is
cat.
in dog.
C is
I
in
got a lot
dog.
of C's. Are we in agreement it's C? And it is AP inspiration. That's your AP upper ribs. That's your shows the posterior ribs above the diaphragm. So push the diaphragm down. Down. See how you got to think about it a little
I
bit
thought you
differently?
said down. Like I thought you said pushing them down, down.
I thought I said the curse word.
Yes, the bad word.
Like Hoover.
Like, dang, he really
I was
trying
like,
to make
yeah,
us
he
know
wants,
it.
yeah, depressed
I
down.
am very G-rated.
Yeah. I was like,
Do I ever curse? No. I don't like using curse words. I might say something in my mind, but I got 3 little kids and model their behavior after their daddy. I can't just say any bad
They're like,
words.
sponge.
I don't like kids using those words.
What about your one?
No, I don't
That's
like,
a grown woman.
I don't like using curse words. I feel gross using curse words.
I don't. No,
To me, it just, I always, you know, I always say.
It just flows naturally.
You know, I always say, and I'm sorry if you like to use curse words, I always say there's always a much more intelligent way to express my frustration than using a curse word. That's how I look at it.
put your hands on
Feel better.
Just,
Make me
you
feel
know,
better.
just put your hands on them.
Makes me
Get
feel
get
more
him.
angry.
Just get him.
Just get out.
I used to have a potty mouth,
He said potty mouth. He said potty
but
mouth.
I used to curse like a sailor sometimes, but I was like, no, there's a much
And
more,
getting off of work.
there's a much more intelligent, better way to express myself than doing that. All right, guys, let's look at some of these closely. Now, be careful. Look very closely. You saw this image before, but there is a subtle way to tell the difference between AP and the PA ribs. If you cannot see the anterior ribs very clearly, I'll add that as well. There's something else we can look at, that being the top portion of that chest. There's your clue. Which projection are we looking at here?
It's C.
I have here a C, I hear an A.
I think it's A.
It is A. Why is it A?
It looks
Look at
like
the
it.
clavicles. If your clavicles are all the way towards the apices, that's an AP. If they're a little bit lower, that's going to be your PA. It's only if you can't see the difference between the posterior and anterior aspects of the ribs clearly. It's another way to tell.
Why do you say
Look to the clavicles. I want y'all to think for
so much
yourself.
headache?
I'm trying to make you critically think.
Let me say that, and then I'll critically.
So then,
You'll thank me later. Don't worry.
are there other indications?
Well, usually you'll look at the ribs and see what's like really popping, but in this one, this is an overexposed image. We can't really use the ribs. But there's another way we can tell.
The marker.
Huh?
The marker.
Not necessarily.
Not necessarily.
No. No, some say flip it,
Yeah,
you
they
rely
don't
on that.
flip it.
Look to the clavicles. In your AP exams, your clavicles sit high. PA, they're gonna sit a little lower. That's your key indicator here on out, okay? It's a subtle difference, but it's one you need to identify. We're moving on forward. I told you we're cranking up the difficulty dial here this semester.
And you said we shouldn't use the heart as well?
You can't really rely on that. Depends on how they're flipping the image.
Okay.
You can have cases of dextrocardia. You never know what's going on there.
Dextrocardia is the.
Flipped heart. I got one coming up. What is that?
Sternal RPO.
Well, it is a sternum, but you gotta be more specific than that.
The
It's not
PA
B.
oblique sternum.
It's not C.
That is a
Okay,
PA
but
oblique
it's a-
sternum, but what specific oblique is it, guys?
RAO.
REO. Do we ever do an LEO?
No.
We do not. We do not. So remember with the oblique sternum, you always assume for an REO because that's the optimal position. Technically, the only one we should do unless it's an emergent trauma case. If the question does say something about trauma, though, what's the alternative that we can do?
LPO.
LPO. LPO. Correct. All right, what is this? Look to the marker. That's going to be your indicator. This is an oblique ribs x-ray. What did we just talk about? How would you know what oblique we're looking at?
That is a elongated right side down.
I just have the right side. Because of our
Let's see, let's break it down. The right side's elongated. That's our first clue. We're marking the side touching the IR. Which oblique
So
has
RPO.
that side touching the IR when it's elongated?
LPO. I mean RPO.
Yeah, RPO. So that's an AP oblique. AP oblique. If the left marker had been over here, that would have been an LAO. PA oblique. We're gonna keep practicing that.
Okay.
That can be very confusing, but you gotta look to the marker, guys. You gotta look to the marker. The right side's elongated. And for our AP obliques, we elongate the sides down. I said for markers, we always mark the side down. Therefore, right side's marked, right side's elongated. It can only be the RPO. This is what's elongated. This is for short. Look how much thinner this side is compared to this one.
I'm looking wrong. Yeah, yeah.
All right. Did y'all not learn about foreshortening and elongation?
Yeah, we did.
Yes.
We did.
Elongation does not mean it's long. It means it's stretched out.
So
That can be
wider.
wide
That's
or
wide.
vertical. That can be horizontal or vertical, guys. Elongation just means stretched. That is not stretched, that's thinner. That's a thinner portion. We're not concerned with any of that. This is the star of our show over here. See how long the ribs are now in comparison to the left side? I'm gonna give y'all some more practice images on this. on
That's
Friday.
why
Kindly put the correct answer there.
Correct answer is AP above the diagonal.
Thanks, sir.
I'm gonna get y'all some more review on this. I can see that's giving y'all some trouble. No, what? What about below? I don't know if I have one of those, but like I said, I'll find some more practice images for you guys for Friday. Make sure I hit all the aspects of that for you. There's a regular AP lower.
There you
Oh,
go.
I just gave you the answer. AP below diaphragm. What answer is it, guys? Oh, yeah, okay, D. Okay. What is that?
Ooh.
That's the reverse of what we just talked about.
Well, you said the clavicles are lower.
That's good.
PA above.
Those are lower, they're not as close to apices. So that's gonna be PA above diaphragm.
So the clock goes.
You can really tell that.
that's something that you, like, we haven't done that in the past, but now that we're advancing our QAIs, guys, developing our X-ray vision, this is something you start noticing on that difference between PA and AP chest images or ribs. I'll get some more practice on this as well. What is that? I hope we know that.
It's 72.
Little sternum. Very good. Very good.
Can you go back to the first rib ones?
First rib one?
I think it was the first one.
This one here?
Yeah, thank you.
Can y'all really see how much higher those clavicles are now? In
Yeah,
comparison?
I need to.
They're like midway from the first one,
Mhm.
and the other ones are more.
It's a subtle change, but one we gotta start identifying here on out. And then let's go to that PA again, so you can see how they lower. Look at that. Seeing it now?
Yes, on this PA, it's going to be a little bit more separate.
All right, I think I just got a few more images here, guys. Just basically, we're gonna QC some of these images. Let me know if you think it's an optimal image or if it needs some help based on our evaluation criteria. So first off, what in the world is number 1 on the top left? It might be easier to see on the TV screen.
I see, Jordan.
Oh, it is easier.
It is really.
So I'm being mean on this one. It fits the theme of the other 2 images you already see up there.
You said top left?
It's
It's
a sternum
supposed to be an
X-ray.
RAO.
That's a sternum X-ray. What mistake do you think that tech made in that image?
Too much oblique?
They're not oblique.
They're not oblique enough.
Oh, no.
They're barely oblique. They probably did like 5 degrees on that one. Also, look at the centering. Centering's directly on the spine. It didn't center towards the elevated side where the sternum is, and that collimation's open way too wide. Can you even see the sternum?
No.
Just barely. You just barely can.
So it's not a T-spot?
It's like, it's right here, guys. Here's the sternum. Where I'm putting my laser. It's very thin, very hard to see. That's a poorly positioned, poorly techniqued,
I see
poor
it.
everything REO sternum.
What track is that? MC.
There's nobody here. I hope not, at least.
My
What about this one here? What is this, first of all?
Lateral sternum.
Is that an acceptable image?
No.
Why not?
They collimated too much.
They got too slap happy with the collimation, huh? It's a reverse problem. So we're cutting the top and the bottom off there. All we really see is that sternal angle. Yeah, yeah. So even though
And
it's
they-
nice and clear, they got good chest puffage going.
They cut up their marker too.
They're
So
cutting
why the space in the sternal angle, sir?
Are they
You tell me. Why would there be a space there? What is
It's
that?
oblique, sir? Because I don't know.
Why is there a space in the sternum there? That's a good question you should know.
Fraction.
What is the sternal angle?
It's like
It's a joint?
It's a joint.
Oh, I see, so it's
Joints should
curved,
have
yeah.
space.
Right, sir.
You can see the capsule. It's pretty cool.
All right, bottom image. What about that one? What do you feel about that one?
Ooh, they hurt. They could
That's
for
okay.
hard process.
A little bit of superimposition. We could have puffed the chest a little bit more. Could have centered a little bit better. No marker. But we do have the whole sternum, yes? We do. We
Do you have the xiphoid there, sir?
Right here. Right there. That's a little hard to see on this screen. You can see it better on the TV screens. All right, let's move on. What are these?
Old images.
Old images. These are SC joint images. What's the one on the left?
bilateral?
That's the PA bilateral. And the one on the right would be what?
Yeah, cause the head is twisted to the side though.
That would be unilateral, correct. Correct.
The
Is
head is, where does the head, go to the unaffected?
So
What
what
happened
do you
to
think's
the
wrong with that
right
image?
The
Now here we go
markers.
critically thinking.
So it's elongated.
The marker's
left
not right.
side.
This is a good example of the importance of not using digital annotation and correctly using markers. We turn our head towards the unaffected side, which is the upside on SC joints. Therefore, based on that info, what did this tech do wrong?
Should have been bilateral, because you have the right and the left, so it should have been something.
He used the wrong markers and didn't flip the image.
And thought the head was gonna say,
So this should say R, this should say L, and it should be flipped.
okay.
This shows you why it's dangerous to mismark films. Let's say there was a major issue here, guys. This person just got misdiagnosed. Because the doctor's gonna say, left SC joint dislocated, when it's actually Right. Yes. Let's go ahead and look at these two ribs here, guys. And once again, well, we know what the left one is. Yes? What is that? How do you know it's PA? There's no marker. Very good. Are y'all noticing the clavicle difference? Clavicles are lower. Had those clavicles been higher? In AP. What portion of the ribs is this focused on? Upper what? That's only half the answer.
Interior.
Upper anterior. PA focuses on upper anterior. Because what's touching the IR, guys? Front of the chest. Let's go to y'all's favorite here on the right. What specific oblique are we looking at in that image?
Well, there's no marker.
There is a marker. What are you talking about?
Where?
The left side.
Yep, it is.
Look on the TV screens.
Oh, okay. So the left side is elongated?
We mark the side down. The left side's elongated.
So it's a PA oblique, oh, sorry, AP oblique,
Which one?
LTO.
Oh,
That's an AP oblique LPO. Left side's down. It's also elongated. We mark the side down. L, it has to be an LPO. I still see some of y'all looking vacant stares on that. I'm gonna give y'all more practice images on Friday as part of our review, I promise. And we're gonna practice all this in class. We're gonna come back to that. And real quick, because I'm running out of time here, guys. This is an example of that obsolete exam that we don't do anymore, that unilateral AP ribs. We do not do these anymore. That's how it used to look. Now we just basically do everything bilateral. And this is a very poorly collimated AP lower. This kit, is there a reason I know this is an AP lower, not a PA lower?
Because we don't do.
It's a trick question, and you're correct, because we don't do PA lowers. Do you see how I can trick you on a test with that? True or false, we're looking at a PA lower. True or false, we're looking at a PA lower ribs. If you're glancing at that question too fast and you see lower, you're gonna say true. But why is it false? Because I said PA lower. Do we ever do a PA lower? No. We only ever do AP lower. AP lower. All right. That's going to be the end of chapter 10, guys. I know there's some areas we're still confused, but do not panic. We'll spend the entire class on Friday doing a review of the types of questions